Hi, this is Brian Kim. I'm going to share with you case number 14 and the best way to do cataract surgery series. This is a medium pupil, 1 to 2 plus density, and the patient has a strong Bell's reflex. So I'm going to show you my standard technique, double chop, cross chop, mechanical fracturing maneuvers, as well as my technique on how to keep the eye straight during the surgery. This is a corneal mark to help me center and size my orexis. I make my paracenteses, one on each side, and then I'm going to inject intracameral lidocaine and epinephrine. This is dispersive viscoelastic. I make my triplanar corneal incision, make a vertical groove and then tunnel and then enter the anterior chamber, do my capsular orexis, but I'm going to hold the eye using my cannula. This is a right eye and the patient was belling upward, which is towards the left of the screen. So I'm using my cannula. I'm actually laying it very gently on the patient's forehead, brow area, and I'm able to do my capsular orexis, which is a puncture style orexis. I puncture and then pull down and then sweep a little bit to the right to create my flap. And then I'm grabbing and re-grabbing as I go. You can see the cannula is really keeping the eye nice and straight. And I'm able to use my corneal marks to help me center and size my orexis. I do my capsular fornix hydrodissection technique, place the cannula out to the equator, point it down towards the nerve, and get a nice fluid wave, decompress on the left side, and then go to the right side, and then begin to spin the lens. You can see the lens spins nicely. I lift the incision with the chopper and place a phaco tip into the eye without irrigation to minimize Descemet's trauma. I'm removing the surface epinuclear material. I'm going to do my double chop technique, placing the chopper out to the equator, tilting the phaco tip more vertically, subincisionally, bringing the instruments together, crushing the lens, breaking the lens completely in half, placing the chopper out to the contralateral equator, and then performing the cross-chop maneuver. I use mechanical fracturing forces to crush the lens pieces into smaller pieces, and then emulsifying it using bursts of ultrasonic energy and vacuum. I emulsified that first quadrant, and then using the chopper, I'm able to prolapse the lens piece down and to the right of me. Again, using mechanical fracturing forces to crush the lens pieces into bite-sized pieces, before emulsifying it and using pulses of ultrasonic energy and vacuum to do this. I spin the lens in front of me, place the chopper out to the equator, and crush the second heminucleus. I'm using mechanical fracturing forces to crush the lens pieces into smaller pieces, and by doing so, I'm able to create bite-sized pieces to emulsify the lens pieces. You can see that I'm always placing the chopper out to the equator with the chopper tip leading, and I make sure I go under the epinuclear material. This is very important. People are afraid to place the chopper out to the equator, but if you realize I'm pushing down on the epinuclear material, so I'm actually placing the chopper out between the epinucleus and the endonucleus. This is very important. I'm placing the chopper out between the epinucleus and the endonucleus. And that's because I'm pushing down on the lens material and cutting through the epinuclear material, making sure I'm sliding out. By making sure I'm under the epinuclear material, I'm never at risk of ripping the bag or being outside of the bag when I place the chopper out to the equator. And so you know this, and you see this on my cases because whenever I do these cases, I usually have a nice epinuclear shell. So after the epinucleus is removed, I push BSS through my paracentesis incision. I take the phaco tip out and I switch it with an INA handpiece. I like to do this to maintain the chamber stability and keep the eye inflated. I start subincisionally and work my way around, removing the cortex. With smaller pupils, when you can't visualize the INA tip as you go underneath the pupil, it's very important to make sure you don't use too severe or aggressive aspiration vacuum because you can pull on the zonules. So you want to be very gentle and then switch to polish mode and then polish the lens epithelial cells and any potential cortical material that you may find. You also want to polish the posterior capsule, make sure there's no lens material or cortical wisp that are there. I push BSS through the paracentesis, but I like to pulse the subincisional fornix because there can be some cortical material or lens material into the subincisional capsular fornix space. And then I push viscoelastic, cohesive viscoelastic into the bag. I use my sweep on the right side and I sweep on the fornix on the left side and then switch and then sweep to the other side. And then I place my single piece acrylic intraocular lens into the capsular bag. I place the INA handpiece and I go under the lens, rotating the lens 90 degrees, and I'm able to push the lens and tilt it in such a way that it ensures that both haptics are in the bag. I'm pushing essentially the lens into the capsular fornix. I evacuate the viscoelastic and any potential lens material that's hiding between the lens and the posterior capsule, ensuring that the bag is completely clean. and then I remove the viscoelastic from the anterior chamber, and then I hydrate my incisions. So this is, again, a medium pupil with 1 to 2 plus dense lens and a patient with a Bell's reflex. I'm able to keep the eye straight using my cannula technique, use mechanical fracturing forces to crush the lens into small pieces and emulsifying it. I use my corneal marks to help me center and size my orexis. You can see this patient has a perfectly centered lens with 360 degrees of overlap and with no ultrasonic energy used for this entire case. I hope this was helpful to you, and thank you for your attention.